Anahita is from Cornea and Ear Segment Services, L. U. Prasad Eye Institute, Vijayawada, and she's going to talk about allergic eye diseases. Over to you, Anahita.
Thank you, Dr. Vikas. So, good evening, everyone. Today I'll be discussing the management of uncontrolled allergic eye disease. As we know, ocular allergy can present to us in different ways, and there are several therapeutic options available out there for the management of these cases. Because of this, what happens is that when we have a patient in our OPD who is not responding to therapy the way we expect them to, we are often posed with the question, what is the next best course of therapy for this particular case? So this is even made complicated by the fact that there are so many options available out there. So how do we handle such cases? The first step is to classify the disease based on the periodicity and the severity. Let me take you through what these terms mean. A patient is considered to have an intermittent disease if the inflammation-free intervals are there of at least 2 to 3 months after discontinuing the topical therapy. And if the patient has a relapse within 1 month of stopping the anti-allergic medications, then the patient is said to have a chronic disease. Now, when we are trying to decide if the patient has an intermittent or a chronic disease, we have to obtain a very thorough past history, especially in terms of prior use of steroid and what was the response to this. So basically, we need to ask the patient if they have used steroids, whether they were symptomatically better with them, and once they stopped, how quickly did they relapse. So this will give us a fairly good idea if the disease is intermittent or chronic in nature. So next, coming to the classification of the severity. So this is a classification that was proposed that classified ocular allergy into mild, moderate, severe, and blinding. The disease is considered mild if the patient has only symptoms with a few papillae. It is moderate if the patient has up to 6 clock hours of limbal involvement with limbal inflammation, horn or tranta spots, or very fine SPKs. If this progresses to annular involvement of the limbus, or if there are coarse macroerosions, as can be seen over here, because of giant papillae, then the disease is considered to be severe. And if this progresses until the patient develops total limbal stem cell deficiency, or if the patient has a very severe shield ulcer with scarring, then it is blinding. So, is it sufficient just to rely on clinical signs to decide whether the patient has an uncontrolled disease or not? Very frequently, we will see such a case in our OPD where the patient has diffuse dispersion of pigment over the surface, minimal surface inflammation, and a few papillae. So in these cases, it is very important to, again, go back to the history and ask the patient if if they're symptomatically better. So if the patient says that a couple of months ago, I was symptomatically worse, and after using the medications, I'm feeling better, even with this type of a surface, it is not an uncontrolled disease, because in such severe cases, even when the disease is quiescent, the ocular surface may not come back to normal. So let us see now how to manage these cases. When the patient has a chronic disease with mild or moderate severity, in the acute phase, the usual armamentarium of drugs is used. The patient is started on a course of soft steroids with either loteprednol or fluoromethalone. And in addition to this, antihistaminics and mast cell stabilizers are also used. These are the commonly used medications. Mast cell stabilizers, they take some time for the onset of action. They take around 2 to 4 weeks, whereas the lower group of drugs, which are dual acting, have a faster onset of action. Because the disease is chronic in nature, the patient will require a maintenance therapy, either in the form of topical steroids, low dose, every alternate day or once in 2-3 days, or the patient can be placed on topical immunosuppressants with cyclosporin and tacrolimus. Both are calcineurin inhibitors, and they inhibit the effect of T cells. These are the concentrations in which the drugs are available. Again, these medications, they also take around 4 to 6 weeks for their onset of action, and so they have to be combined with topical steroids when they're initially given. Irrespective of there are several studies which have looked into the efficacy, and they have established the safety and efficacy of these medications, and comparative trials have not found any difference between cyclosporin and tacrolimus in the use for VKC. So irrespective of the severity of the disease, patient counseling is a very integral part in the management of ocular allergy. The patients have to be counseled regarding the chronic course of the disease. They have to be explained that this is a disease where there will be a relapse, so that they don't get alarmed and visit a different doctor every time. Otherwise, what will happen, they will get overtreated with steroids, And then we will have to deal with the slew of complications that is associated with steroid use. And avoiding eye rubbing cannot be overemphasized because this is also plays a very important role in the pathogenesis of the disease, and patients have to be counseled that if they have the urge to itch, they can use cold compresses instead. So coming to the management of severe or blinding disease, in these cases in the acute phase, potent topical steroids, prednisolone acetate 1% in a tapering dose is administered. And again, they will also require maintenance either with topical or oral immunosuppressants. So typically, topical immunosuppressants with cyclosporin or tacrolimus are preferred. Oral immunosuppressants are given to those patients who have a very severe disease which is also chronic in nature, or the patient also has associated systemic allergy. So the commonly preferred systemic immunosuppressive agents include oral steroids, cyclosporin, omalizumab, which is a monoclonal anti-IgE antibody which is injected subcutaneously. So this was a patient who presented to us, a 15-year-old child with severe papillae, giant papillae, and the child gave history of being on and off steroids for 9 years. And the patient was started on a combination therapy of oral steroids and oral cyclosporin in addition to topical therapy. And after 3 months of this combination therapy, a dramatic response was seen to the oral immunosuppressants. This similar response has also been reported in literature, both with combination therapy and cyclosporin in isolation, as seen in this case, which is a case of atopic keratoconjunctivitis, which was also treated with a combination of oral steroids and cyclosporin. Blinding disease, in addition to the topical therapy and systemic therapy, also requires surgical therapy. So in the papillary variant, where there are giant papillae, supratarsal steroids are administered, or in, again, very severe cases, shave excision with conjunctival autograft and mucous membrane grafting can also be done. When there is limbal stem cell deficiency, the treatment of choice is limbal stem cell transplant. So a little bit more about supratarsal steroids. So several studies have shown that the actual medication, all 3 drugs have a very similar onset of action, and within 3 weeks there is resolution of the shield ulcers that is seen. However, it is very important to note that when supratarsal steroids are given in isolation, there is a recurrence of the disease within 6 months, which goes back to its original severity. So the point to be taken here is that supratarsal steroids, even when they are given, in addition to that, topical and systemic immunosuppression should be given to the patient. Before I conclude, I'll just add a short note on immunological tests. Now, these are very well established in systemic allergy. In ocular allergy, their role is still being explored. Both in vitro and in vivo tests are available. Total IgE can be done, however, it is non-specific. Serum IgE for a specific allergen is also being carried out. So here, this was a 14-year-old patient who had uncontrolled VKC and allergic rhinitis. Her total IgE was elevated. You can see it's almost 600, whereas the normal for that age is less than 200. So we went ahead and carried out allergen-specific IgE. Now, the type of allergen depends upon what is the most common allergen in that geographic area, and this is the panel that is available in our geographical area. So here you can see the patient had sensitivity to these agents. And so once the agent is identified, we counsel the patient to avoid them. This has also, again, been reported in literature where complete resolution of the signs was seen once the allergen was avoided, and this way, administration of either topical or systemic immunosuppression can be avoided in these cases. So the in vivo tests include skin prick and patch tests, which also work on the same principle where the allergen is inoculated in the skin and the wheal and the flare is measured, and the allergen that the patient is sensitive to can be identified this way. So in conclusion, patient counseling is one of the most important parts of managing an uncontrolled ocular allergy. They have to be counseled regarding avoiding eye rubbing as well as the chronic nature of the disease. Maintenance therapy for patients who have chronic, mild to moderate disease is needed after the acute phase resolves. This can be given with either topical steroids or topical tacrolimus or cyclosporin. Systemic therapy is reserved for those patients who have a very severe disease, which is also chronic, or they have associated systemic allergy as well. Thank you, everyone, for your patient listening.
Thank you, Anahita. That was really nice, and you covered up most of the things which a general ophthalmologist would wonder. I just have one question. Now that we have so many molecules which you showed that you can give any of the antihistaminics or anti-allergic molecules, how do you decide in your clinical practice where do you start with? What is the steroid which you start with, and what is the anti-allergic molecule which you start with?
So, again, depending upon the severity, if the patient has a moderate disease, I will start with Cromal 4%. And with this, I give loteprednol. I start at around 6 times and taper it slowly over 6 to 8 weeks. If the patient gives history that he keeps having recurrent attacks, I will add topical tacrolimus ointment once at night. And if the patient has a very severe disease, then my drug of choice would be prednisolone acetate right from the get-go.
So, Anahita, can I ask one question, please? For that article or the database that you have shown, so in shield ulcer or severe where you have a giant papilla also, did you see a comparison between supratarsal Kenacort vis-a-vis systemic steroids?
No.
Okay. So that Himanshu or Dr. Maskati, somebody want to, or Dr. Nikhil? So my question is that supratarsal Kenacort vis-a-vis systemic steroids.
So actually, I think if you have severe tarsal disease, many of the times these children have shield ulcers, and we need to debride. So the clinical situation whereby I often use supratarsal steroid is when there is a child with uncontrolled VKC, with cobblestones, with a shield ulcer which needs debridement. So I need to give them some sort of anesthesia and debride the ulcer. At that time, I would try to give a supratarsal steroid. Systemic steroid probably may not be required if the local steroid works. Of course, the steroid response, we may say that we will watch the IOP, but again, it's quite a difficult job. So that is something we have to keep in mind. But if you have very severe disease, then probably systemic steroid will work better, faster probably. But
yeah, I very rarely would start systemic steroids. I do a lot of I rely a lot on cyclosporins. So both the orosporin drops, which are burning and stinging, yes, and the tacrolimus ointment, which can be given through the skin or into the eye. If there's a lot of irritation in the eye, there are people who, many countries of course don't even have the eye ointment, so they have to use the skin ointment outside. Seems to work. So all this has lessened our dependence on systemic steroids, at least to a large extent. Other simple lid hygiene measures also do tend to help, simple cold compresses and things which I think are underestimated in our treatment regime.
I can also recollect that, I've had instances of refractory shield ulcers that I have given supratarsal steroid, given topical steroid, anti-inflammatory, and, it just fails to resolve, and then I had to resort to maybe oral steroid for a short period of time, and then probably they healed faster.
So I have one question for the panelists as well as you, Anahita, that an allergic eye disease, or rather allergy of any form, is not a disease of the effect what we are seeing. That's the effector part which we are seeing, the immune part of it. But that's not the root cause, right? So when we are not treating the root cause, what are we expecting? We are expecting a natural desensitization which would occur naturally in many of them. So with the presence of now the sublingual immune therapy, do you think there is a role that we can more often refer to the immunologist these allergic eye disease patient, or well, we don't need to go that level?
So again, practically, if we have patients who can be managed safely with local treatment and they're doing quite okay, probably I may not refer them, all of them. But when we come to a situation where the disease is refractory, or we need exceedingly higher doses of steroid, or we need a therapy which seems frightening to us personally, I think in those situations, 100% try desensitization, allergy testing, and so that possibly we can reduce the pharmacotherapy that is required to control the disease.
I think I have nothing more to add. I would entirely agree with Nikhil that we would use these measures where we have to refer to our rheumatologist colleagues or your physician colleagues only as a last resort. Almost 95% of the patients we are able to manage and still keep them off steroids and safe.
The other thing we need to remember is the desensitization therapy also takes several years to take effect. So we cannot expect quick results. It might take 3 or 4 or even 5 years for the effect to be there. So it's a parallel treatment that can be continued. Just like sometimes somebody will say, I'll take homeopathy. We don't refuse it, but we need to do what is required for our control.
The compliance with these therapies is quite low. I used to refer a lot of patients for the allergy testing and then the desensitization injections. But most parents dropped out because of the multiple times that they had to visit and get the injections done. So we seldom use it. Yes, you had a question.
Sir, I just wanted to add something in the doing screen prick test in the allergic conjunctivitis patient. There is a study published in an allergy journal. Kids who has taken oral immunotherapy or sublingual immunotherapy, these kids are less prone to go in asthma in adulthood. So if you treat these patients at that stage with the systemic, with allergy testing and immunotherapy, we can prevent the allergy march also. So even though patient will be in a quiet stage afterwards, but after few years, he or she may go in a other systemic allergic disease, and that desensitization helps to prevent such kids to go in other systemic complication of allergy. That study has been published. And second thing about the what sir has mentioned for the allergy shots, patient has to visit frequently. But sublingual immunotherapy is a good choice for that because patient no need to visit every time for the injection in the hospital. 1 month, 2 month or 3 month, as we are practicing in allergy, we are doing desensitization and immunotherapy. So we can send it with courier also so that or 3 monthly we can analyze such patients. So with sublingual, we can manage that follow-up problem also. Thank you.
Thank you. I think we'll move on. Thank you, Anahita.